we're the biggest health system in Indiana. We employ about 40,000 people. I can't keep track of all our hospitals anymore. I guess it's 15. We're building another one. We have a lot of building going on. We have 2 separate academic campuses that are about a mile apart, and we're building a $2.3 billion building to consolidate those that opens in Q4 of 27. I manage about, so I'm the VP of OR operations, which is a nice title with no power. It's just super interesting. We manage about 200 operating rooms across our system, everything from the academic health center to ASCs to critical access hospitals. We are the only academic health system. There's 3 trauma systems in the state, or 3 trauma centers in the state, level 1, all of which happen to be within 5 miles of each other in central Indiana, so that's kind of not well planned, but it is what it is. So yeah. It's an interesting, dynamic, busy place, as I'm sure yours are as well. Yeah.
Well, similar to some of the stories you heard earlier from Kim and Tammy, IUH is partnered with us in a way of started with surgical growth, and then we also implemented our inpatient solution, and now we're going through the process of our PCC solution. But going all the way back to the beginning, how did we get here, right? Like, what were some of the challenges that you were dealing with in surgical growth that led us to this, this partnership?
Yeah, it was just, I think it's pretty standard issues that I think, especially if you have multiple different ORs, not really a coordinated way to see the time available, to capture time, a lot of phone calls back and forth, looking for time between the office and facility schedules and those kind of things. It just was very inefficient, and not really having a lens of knowing what's out. We have a very common thing, which unfortunately we still have, but it's getting better, is that the surgical leaders would tell the C-suite, well, I can't recruit because I can't get any OR time, and then you're looking at utilization. That, like, when I started, our system OR utilization was 41% when I started my job 3 years ago. So obviously there's plenty of space, and so it was just really poorly coordinated.
Yeah. And how do you think that's going to date?
Well, we're up to like 53%, so that's pretty good. It's really helped. We're pretty early in our journey, so our longest running sites on Qventus are 13 months, and then we have a couple that were rolled in after that. And I think it's interesting, going back to the operational thing that Kim was talking about earlier. We have some wins and losses. So I have one facility who has probably made 7 or 8 moves based on the data. I mean, to the level of, they went into the block time by AM and PM and ran the time slices and found that who was routinely finishing early and who was finishing late, and extended the block time for 4 different surgeons across the week based on that, which I think is pretty deep in the weeds of using the stuff. And then I have another facility whose block utilization is across the OR is 61%. They've been on the platform for a year and have not made a single block change based on the block data. So, like, big win, big loss. So I need a herald. Like it was so Harold, if you're tired of 100-degree days, there's no 100-degree days in Indianapolis. Now, it's probably a good way to not get invited back, right? Steal other people's folks. Right. But just to the point that I think that the platform does a lot and creates a lot of data for making decisions, but you still have to have a plan and accountability of how those decisions are going to be made.
Yeah, very fair. I think that's what we see across all these health systems, right? Is that we both have to be leaned in. We both have to have that process, like you're saying. And I think that the more that we're communicating and the more that we're engaging, which I feel like it's kind of unbelievable. Dr. Virkus a lot of times will say, hey, we see this and we need to get on the phone sometime soon. Do you have some time over the next couple of weeks? He's like, are you ready in 10 minutes? And then he shows up in his scrubs and he's there. And that's the type of engagement and the accountability I feel like that you put into this partnership, which makes it more successful. You had options, right? When you're looking at how do I take a a health system that's in the 40% range of utilization and moving it forward. Like, what brought you here? Like, why a partnership with Qventus? Why using the technology? Like, give us a little bit of background on that.
Yeah, I'll save some of the details. We did an RFP. Qventus kind of came in first. Another vendor came in third. We ended up doing a pilot with the vendor that came in third as the proof of concept in 2 of our facilities. We were able to prove the ROI, and once I got the C-suite convinced that the ROI was good, then I came back with, I think we should change vendors, which raised quite a few eyebrows. But I actually think that it's worked out very well. You know, what we saw and what led us to change paths is we just thought that Qventus was a little bit more nimble, a little innovating a little more. The vendor we were using, like, so my favorite example is we were going through implementation, and we'd say like, "Hey, we don't see that you're doing this. Like, can you do that?" And like, "Oh, that's a really good idea. Like, we'll write that down." And it never really got addressed again. We were going through implementation with Qventus, and I remember this one day we had like 6 things that were like, "Hey, we're not saying this, and this." By the next implementation meeting a week later, they had built 2 of them. 2 were going to be done in another 2 weeks, and they apologized because like the last 2 were going to take like 2 months. And so that speed of innovation, I think, is what we saw. While we're doing our pilot with the other vendor, and keeping in communication with David, or more likely David keeping in communication with me, we just kind of talked about that stuff. And like even when we're doing the RFP, going through the RFP, I remember talking to David and I said, "Hey, it'd be really cool if you guys did this." And it was kind of a big thing, and I don't even remember what it was. So we met probably a year later, because long story of our contracting process, but we were talking about this again. He's like, "By the way, if you went live now, that thing what you mentioned back in the RFP, like that's all built out now." So it was just that kind of stuff that had kind of really got our attention. And we were actually kind of blessed. We're a Cerner shop when we were going through all this process. And we just got really lucky. We had Banner, who was a Cerner shop, and switched from another vendor to Qventus. So that kind of gave me a bunch of resources to talk to them. And then we have a lot of administrative cross-pollination at high levels with Northwestern, and they also switched from another vendor to Qventus. And so a number of folks there, including Lydia, were very generous with their time and kind of telling us the hows and the whys. And it really just made my conversations with the C-suite, a lot easier for, considering it was kind of a pretty crazy idea to propose.
Right. Yeah. Well, we thank you for the proposal. Let's talk a little bit about, I think we've got a slide here that we could talk about some results. Here we go. So just kind of where the partnerships led and your thoughts around how these came about and how we're feeling about this, and maybe even kind of, before we open it up to the audience, talk about like where you want it to go.
Yeah. So, like I said, we're early in our journey, and we have a lot of ROI to still generate. It's really funny because I saw these numbers, I probably spent 6 months after launch, like having to loop back with the C-suite and show that everything's working out fine. I actually don't even pay attention to these numbers at all anymore. I'm much more paying attention to the operational metrics and where we still have opportunity and that kind of thing. But I think that it just became very, very easy. I think that the solution works well. I mean, one of our sites that we brought online, they cover their annual costs in 3 months. And so, like, once I got through that kind of stuff, and I knew that, like I said, I don't pay tons of attention to like the additional numbers now. I kind of know it directionally. We really had a big problem with our robotic usage, as I'm sure a lot of people have. We had 51% of the case minutes in our robotic rooms were non-robotic cases. But then again, people are clamoring for robotic time. So really being able to help manage that was one of our big goals, and that's really going well. And I think there's a lot of like hidden opportunities. So one of my new favorite stories that it's hard to measure. So where I work at Methodist, which is where our level 1 trauma is, we have 32 ORs, and they're broken up into 5 cores by specialty. So ortho has 6 rooms in their core, and CV and PV have a core, and neurosurgery has a core, blah, blah, blah. And everybody was very tunnel visioned in their core. Like ortho would never, like unless we were running into the hybrid room or, helping with some super emergency thing, we would never operate outside our core. And we have 9 orthopedic trauma surgeons in our group. Ortho does about 6,000 cases a year at Methodist Hospital. And I happened to look in the schedule the other day. I had 3 partners operating outside the ortho core. 2 in neurosurgery rooms, and 1 in the general surgery room. And what struck me is, like, that doesn't show up in the volume, and it's like hard to parse out that ROI. But if you think about what that meant, there was 2 other alternatives for that situation if that didn't exist. One is we're doing those after the close of business, late at night, everybody ticked off, and not our best scrub team. More likely, it actually gets pushed to the next day. So that's probably easily 3 days of length of stay that we saved, because we're now looking outside our typical area, because when you go into Time Finder, it doesn't just show the ortho core, it shows all the other rooms. And so, like, I think when there's a lot of that kind of secret benefit that until you're like really deep in the operations and you kind of see how the cheese is being made and moved, you don't necessarily appreciate like on a slide like this.
Right, makes sense. Well, before you know it, it says we have 5 minutes left. So we're going to turn it out to the audience and see if we might have some questions. If you do, and raise your hand. Can you wait till you get to the microphone? We were having a hard time hearing across the room fully, and they're taping over there. But any questions from the audience? Sure, right here. I think you've got a mic coming right behind you. There we go.
Thank you. The previous panel that was up discussed that the efficiency measures that create increased capacity are that you need surgical growth to fully appreciate the ROI. I'm wondering what your thoughts on that are, because efficiency creates capacity. Obviously, if you're growing, that's wonderful. But if you're not growing, retiring that capacity is also beneficial. It reduces the cost of production. In your realization of the ROI that you're presenting, was that dependent on growth?
Yeah, it was purely based on added surgical cases. Like I said, there's all these other kinds of things that you could layer in. My bar was to show that the ROI was positive. And I haven't really been asked to quantify the number over neutral, which is good, because it gets really very difficult. Like, you're all doing 10 different things to grow your volumes, to improve your utilization, all that kind of stuff. And so, tying that to the platform and separating that out, was very difficult. And in our early phase, like in the first 6 months, we had this one hospital, and they were up 120 cases, and this is a 12-room OR that only runs 10 rooms typically. They were up 120 cases from the same 6 months prior. And the president says to me, well, how many of those are from the platform, and how many of those we would have had anyway? I'm like, well, I can't answer that, but this is what I can tell you. The number of cases you need to add to cover your costs for that 6 months was 18. Will you give me that we generated more than 18 of those 120, at least 18 of them were from the platform, and so that conversation just kind of stops. But I do think it's extremely difficult if you want to pin this is literally, this is the number. That's very fuzzy math, which I feel very fortunate that I haven't had to help generate that number other than, it's positive.
Yeah. Good question. Other questions? One here? Yeah.
Hey, so you mentioned that you had a leader that sounded very engaged and one not so engaged. What did you do to get them engaged, or have you?
Well, I'll let you know what I am doing. It's kind of weird. So as I mentioned tongue-in-cheek, I'm VP of OR operations, and none of the peri-op people report to me. So I usually refer to myself as an internal consultant. And so like and it's a weird relationship because I try, like, you're trying to create the working trust with the peri-op leaders, and when they're not doing things that they're obviously not, should be doing, it's very awkward because you can show them and show them and show them, and then at some point you kind of need to escalate, which is not necessarily something I wanted to do. So the way I usually would go about it is like I would pull data, and I would email the peri-op director screenshots. So like one of the parts that I like best, other than the old normal things, the unique Qventus piece of data that I love is the unreleased, unfilled, that metric. And you can pull your hospital, you can rank it by good to bad, and you can just, you can see. And so I'll screenshot that, and I'll send it to the peri-op directors and be like, hey, I'm not sure you knew about this, you should know about this, but I'm not sure you knew about this. Like, you might want to have a talk with these people. Either we're not sending the messages to the right people, or they're just not being good citizens. Sometimes you have to send it more than once, but that's how I got that one group really engaged. Like, once I was able to show them where the data lived, they really just kind of took off. The people that are not moving as fast as I want, unfortunately, like now I have to kind of like go up to the COO and start sending the CMO the data, which is, I really don't like that, but it is what it is.
That's how, so you're just nudging them along.
Nudging.
That's
Yep.
good. Thank you.
Yep. And trying to make it, I think the easiest thing was to try to make the data easy. Like, you'd like them to get to where they can curate the data themselves, but while they're still learning, having me or somebody on my team show them the data that they should be looking at and how to get it.
Other questions? Back here.
Oh, geez.
Yeah, great. So I think Walt, it was wonderful to partner with you all starting in surgery and surgical growth and efficiency. How did you think about continuing innovation, both yourself and internally in the organization, about expanding to other areas into pre-op and inpatient and other problems that you could solve?
I think it just became a natural evolution. One of the things that we identified early, and I didn't say this. Like I had other people higher up in the C-suite say to me that they appreciated the process with Qventus. Like my IT guy that I worked with this said it was the most prepared, knowledgeable sales group, if you will, that he had ever worked with. But at the same time, I had a number of people comment like they never really felt like it was a sales pitch. It was very partnery-ish from the very beginning, and there was a lot of people that noticed that. And then when we had good results and we started talking about the other things, it just made that, a lot easier. I kind of wished we had taken Kim's advice and done inpatient first, although who knows, we might still not have the perioperative contract signed if we did that. Since I started getting peri-op shepherded through, we've been through 2 CIOs, and we've decided to change from Cerner to Epic, and everybody left to implement inpatient. So it took us Courtney, what was it, 8 months? So the first draft of our PCC contract was 10/31/24, and we signed it 6/30/25. It was awful. And so, and Qventus has been great going through that. Like I literally said to Joe one day, like, Joe, why are you guys still putting up with this? We went through literally 15 deadlines. Oh, we're going to sign it this week. And then our AI committee, found that they were uncomfortable. So it was a super painful process for these folks to live through. But we just kind of persevered, and I think we ended up in a good spot. But I think, even our CFO, who Pat knows, she calls me one day, she's like, what's going on? I'm like, it's super embarrassing. She's like, yeah, I know it is embarrassing. So they were just really patient with all our pain and suffering. Now we're trying to implement PCC and inpatient at the same time, and 90% of our legacy I team is contract labor because all our good people are on the Epic Prep team. So it's super fun times, but we're trudging along, maybe not at the speed we'd like.
We're here. We got here. We appreciate the persistence.
Many hurdles.
Yeah, all right. Well, unless there's another question in the audience, I think we're out of time. These spotlights are really intended to just spark conversation, right? And so we're going to do a couple of them. You now know who Dr. Virkus is and where he's from, and go anywhere from building on the conversation we're having here to, even though Indianapolis is in the middle of the United States, why is it a naval town? I'm sure he can answer all kinds of questions for you tonight. We have all kinds of interactions, dinner, our walk, et cetera. So as I said, as we walk away from here, this is really intended to spark conversation, so keep it up. All right. So I want to thank you, Dr. Virkus, for taking time to have the conversation with us.
Thanks for having me. Thanks, Pat.